MRI procedures of the spine. Um, we covered basically the entire brain last semester, and spine and MSK will be the focus of this semester for procedures. Okay. You have already your assigned pathologies for your case study presentation. Remember, we only have 3. You should get that done in about 15 minutes. Everybody did a great job with their presentations last semester. But just if you want to go ahead and get ahead of the game on that, feel free. Your ASRT modules, you can get ahead and do those for both this class and for physics. Go ahead and knock those out. And then your MR simulator lab. You're just finishing up the book there. Not labs 9 through 16. If you want to work in pairs, I saw a couple of you work in pairs. That's fine. But probably the best way for me to grade it is just to insert a text box into those PDF files and do it that way and just save it. That way you don't have to print it out too. That's just extra paper you don't have to waste. So just download them, insert a text box for your answer, save it, upload, get it done, and this semester should be a breeze. All right, so let's talk about MR procedures of the spine. I know most of everybody here has at least attempted a spine, right? Mostly L spine. Anybody seen some T spine? T spine. C spine. Which would be the hardest one? What do you think out of T? Why is the T spine the hardest? What makes it the hardest? Is it the continuous counting? T, C, 2, 3, 4, 5, 6, 7. Okay, move my field of view up. 2, 3, 4. It's that continuous counting, worrying about making sure you get all the anatomy covered. What helps out when you're counting? What are some things that on the table, on your scanner, that really help out with counting and knowing which vertebrae is which? Those markers, yeah, you can mark the patient, or a lot of those phase array coils already have those vitamin tablets or those markers already built in. So it kind of marks right where your vertebral prominence is going to be at. It's not going to line up for everybody, but it kind of gives you an idea so that you don't have to continuously do that counting over and over to make sure you get all 12 T-spine vertebrae in there. So that is why usually the T-spine is the hardest one to get. And you think about the kyphotic curvature of that T-spine, you kind of have to create 2 axial blocks, cover the top, cover the bottom, and those blocks can take a long time because it's like you're covering 12 vertebrae compared to 5 for the L spine and 7 for the C spine. So generally your T spines take a little bit longer. All right. So let's go over some anatomy. What slice plane and weighting do we have here? Sagittal T1. Is it fat-sided? No? Okay. Why do you think there's more, it looks brighter back here? What do you think's going on here? How do we position for a sagittal, or just for a C-spine in general? How do we position the patient on the coil? Supine. So that phase array coil is behind them. So you're going to get a lot more signal with the anatomy that's closer to the actual coil compared to the anatomy that's further away from the coil. Because remember, that coil can only penetrate a certain tissue depth before it starts to lose some of that signal. And you don't necessarily need that anterior part of the coil for C-spine because it's not like a soft tissue neck. You're really just looking at the spine, which is more posterior. But sometimes if you put that anterior part, it evens out that contrast. But there's also a button on your GE scanners that can kind of reduce the intensity of the signal on your phased array coils, and that's the SCIC on your GE scanner. So if you have that button, it's to suppress the signal intensity of right near the coil. So SCIC on your GE scanners helps to kind of even out that high intensity closer to the coil. All right, so let's go over some anatomy. I'm actually teaching cross-sectional anatomy since Lamise is in here, so I'm kind of in the groove on some cross-sectional anatomy, so let's go over this. What's A? I don't think they labeled this one correctly. I think it's more nasopharynx because the oropharynx is right behind the tongue. This is a little bit higher, nasopharynx. B, anterior arch of C1. So we always count on our MR images for spine. We start with C2, and this is the reason, because it's really hard to see C1 that wraps around C2. What's another name for C1? Okay, and C2? Okay, and what's this part of C2 called? Good. So that's C, dens. What is D? Okay, which one though? Count. 3, 4. Okay, what is F? Okay, and on a T1, you're going to have hyperintensity of the spinal cord, and then the CSF is going to be hypointense. So make sure you have those words associated right, because that's going to be on the test. Hypo versus hyper. You have to make sure you're able to differentiate those terms. Spinal cord is hyper, and you have to compare it to something. So it would say on the test, the spinal cord is hyperintense to the CSF surrounding it. Or you could say the CSF is hypointense to the spinal cord adjacent to it. Things like that. And that's going to be how they word things on the registry. Spinal cord is hyperintense, meaning it has more signal coming from it than the CSF surrounding it. Or it could be phrased, the CSF is hypointense, less signal, than the spinal cord that is adjacent to it. So just know hypointense means less signal, hyperintense means more signal. So what is the most hyperintense area on this patient? The fat on the back of the neck. Here we have a T2, because the CSF is bright, fat sat, because our epidural fat is darkened. It has been suppressed through chemical saturation. You can see the fat within the vertebral bodies has been suppressed, and the subcutaneous fat has been suppressed. This is a whole spine image, which is good for setting up your T-spine field of view. A, it's the pons, part of the brain stem. What's the highest part of the brain stem? Looks like a Mickey Mouse on an axial. Midbrain, then your pons, and then below that is the, from Waterboy, medulla oblongata. And then you go through the foramen magnum and you have your spinal cord. So B is your spinal cord, C is your thoracic vertebrae. We can count. So we got 2, 3, 4, 5, 6, 7. T1, 2, 3, 4. That's T4. We have a disc, which is D. So if that's T4, T5, T6, T7, T8 disc, intervertebral disc, which is impinging on the spinal cord. So what's that called? What's that pathology called? Bulging disc or herniated nucleus pulposus. Annulus fibrosus is the outer, I guess, harder layer, and then the spongier inner layer of the disc is the nucleus pulposus. Okay. E, we have the conus medullaris. That's where the spinal cord is ending. And that usually occurs at what level? 5, 4, 3, L2, L1, L2. And then it turns into the horsetail. And what's the name for the horsetail? Cauda equina. G is the sacrum. H is your spinatus tendon. So you have your spinous process back here, and your spinatus tendon runs the length of all the spinous processes. Tendons are always going to appear very dark on MR images because they don't have many hydrogen protons. So your ligaments and tendons are always going to be dark, along with air and metal susceptibility artifact. What weighting do we have here? T1. Yep. A little harder to tell because you can see the cauda equina, and you have your CSF right here, and it's dark around it. So it is a T1 weighted, not fat-satted. A, conus medullaris, where the spinal cord's ending or terminating. B, ligamentum flavum. So we have the ligament here. Once again, it's dark. C, spinous process. D, we have the anterior portion of the disc. And right in front of it here, we have the anterior longitudinal ligament, which is dark. E, cauda equina, horse's tail. F, L3, L4 disc space. G is our epidural fat. You have a little epidural fat in front of the spinous process here. And then H is your posterior longitudinal ligament. So they run on the posterior part of the vertebral bodies and the anterior part of the vertebral bodies. And that kind of, it helps keep those discs in place. I'm not going to go over all this anatomy. You guys can review these on the slides. But what type of weighting do we have here? T2, not fat-satted. We got the spinal canal, bright fluid. We have the psoas muscles here and the erector spinae muscles posterior. Remember, on a T2 weighted image, our muscles are going to be very dark. Here we have a T2 sagittal C-spine. All the anatomy is already labeled. Looks like you have some kind of either lesion within the spinal cord, or that could be a flow artifact. So what could we do to reduce that flow artifact in the C-spine? Because I think this is not a lesion, but this is actually from the carotid arteries. So what do we normally do to reduce flow artifacts on C-spine? Those saturation bands, put those on where the carotid arteries are coming up, and also over the trachea and esophagus, where patients are going to be breathing and swallowing. Saturation band is basically going to go over all this anterior structure right here to reduce any artifacts. Because these kind of look like MS lesions, so we don't want to mistake those for pathology. Here we have a T2. This is actually a medic. It's to reduce CSF flow artifact, but it's a T2 weighted image. And this is a C-spine. Our vertebral bodies are a lot smaller. You can see the carotids. You can see the vertebral arteries. Spinal cord is hypointense to our CSF. And then here is our T-spine. T-spine sagittal T2, not fat-sat. Be nice if you put a saturation band over the heart and abdomen here to reduce any type of flow artifact. But all the anatomy is labeled. So make sure you know all the anatomy for the test. A lot of these images are going to show up on your test. Make sure you're able to label the anatomy. axial T-spine. We know this is the T-spine because we have the ribs attaching to the transverse process. You have the descending thoracic aorta. You have the lungs here. So you know this is the T-spine. All right, so let's talk about some indications for C-spine. Does anybody for your pathology have any, like, a C-spine pathology? You got a C-spine? Okay. So make sure you put your indication, your contraindications, how to set up for the C-spine, all those things. But here are some indications. So persistent neck pain. I feel like that's a very common one for C-spine. You have those people that come in with tingling fingers or numbness in their hands. That's a very big one. Could be pinching a nerve. Could have a herniated disc. Cancer of the spine, meninges, because remember the meninges not only surround the brain, but they surround the spinal cord. Congenital malformations, MS, any other demyelinating disease. Trauma, so imagine that they're in a C-collar. Do we allow the patient to come into the room with a C-collar on? Yeah, you can wear those. I wouldn't take that off. You can wear those. Those are just usually plastic. Those are fine to go in there. Just one thing you want to check for, though, is if they have like a necklace on, because that could create a metal susceptibility artifact. But the C collar are totally fine. Suspected or known fracture, syrinx. What's that from? What was that pathology that creates that, where we have CSF within the spinal cord? Chiari, yeah. Remember, we have all that build-up pressure because the cerebellar tonsils are starting to protrude through the foramen magnum, creates the syrinx. Infection, that's where we're going to need our contrast. Any cancer or infection, contrast enhance. Myelopathy, arm pain, numbness, tingling in the hands. Patient prep, main thing is your dentures. That could create a major metal artifact. Don't want any hearing aids, necklaces, things like that. If you're an inpatient, you have the metal snaps on the gown. Make sure just to fold those down just like an x-ray, just to get those out of the way. And then these are the coils that we're going to be using. So here is a Siemens coil where we have the coils built in within the table. So we have our phase array coils already built in the table, but then you have to apply your C-spine coil. You can put the anterior part on if you want. And then you have your GE coils. This is an older GE spine coil. I think they still use that at E-Wash every once in a while. And then this is a newer phased array GE spine coil. And it's kind of a pain because you have to take this off and put it back on. If you've been at these sites and how many times you do that throughout the day, it can be kind of exhausting with how heavy that is. So Siemens is pretty nice in that you don't have to constantly take things off and put them back on. Centering, very similar to X-ray, C4, right? We center pretty much everything for X-ray at C4, so why change it up for MRI? Right in the middle of the neck. You could look for that thyroid cartilage there. Hyoid bone. Center right there. Make sure that you instruct the patient to close their eyes, make sure not to blind them. Here are our spine coils for C-spine. We have without contrast trauma protocol. So if you have a suspected fracture, this is the one you're going to want to choose. Flexion and extension protocol. So why do we do flexion and extension in X-ray? What are we looking for? Instability, spondylolisthesis, right? That fancy word for instability, where your vertebral bodies, there might be a fracture within those facet zygapophyseal joints, and it could cause some stability issues when you flex and extend the neck. You can also do that in MRI, but they have to hold it for 3 minutes. That's tough. Yeah. And then you can do your whole body, whole spines. Bauman is obsessed with getting that down to as low time as possible. He was bragging about how he got it down to 45 minutes. I was like, okay. All right, so you start off with your 3-plane localizer. Make sure you're able to see the spine so you can do your counting. Your sagittals, you want to align with the spinal cord. So he's going to be parallel with the spinal cord. You want field of view wise, you want to cover from the pons all the way down to about T4. You want to get a little bit of that thoracic spine just in case there is a herniation or anything going on down there. So don't just reduce your field of view just to get the C-spine. You want to include some of that thoracic spine. You usually are going to choose an odd number of slices because you want one slice to go right through the middle of that spinal cord. Because if you have one good slice through that middle of that spinal cord, that's when you're best going to be able to visualize those herniated discs that impinge on the spinal cord. So any of your sagittals for the spine are going to be an odd number of slices. Typically, it's 9 slices, 9 or 11 slices will get you from one transverse process to the other. And then put your sat band. Put your sat band on the trachea and the esophagus to reduce that motion artifact, and it also reduces the flow artifact from your carotid arteries in your vertebral arteries. Your axials, notice the difference between a typical axial for a C-spine when it's not trauma. All you have to do is cover from C2 down to T1, get all those disc spaces. You're going to want to be perpendicular to those disc spaces or perpendicular to your spinal cord. Make sure you have some oversampling because you're going to be, your phase directions A to P. Keep your sat band there. But if it's trauma, you need to cover from the posterior fossa, so maybe right at the clivus here, down, because you need to get C1, which usually sits pretty high up on C2. So we need to get that entire C1 vertebrae, because that's usually where that trauma is going to happen at C1, C2. You have a whiplash injury, you might fracture that. All right, some indications for thoracic spine. You can see here a lot of these are very similar, but a lot of times you're going to be scanning T-spine for this reason mainly, is this suspected or known fracture, that compression fractures. So do you guys see those patients that are extremely kyphotic that come into your radiology department? Typically, those are people that have several compression fractures right at that normal bend of the T-spine. And you're going to be assessing those patients, and it's really hard to get your patient on a table when they have extreme kyphotic curve. So a lot of times you have to really boost up their lower body to lay their back flat onto their MRI table. So you're going to be using a lot of pillows, but then you're working against, their feet are going to start to hit the top of the magnet. So you're going to have to kind of find a good in-between to make them comfortable, to get through that 30 to 45-minute scan, but then to also get their spine as close to that phaser recoil as possible. So most of the time when we're looking at T-spine, it's really looking for any type of cancer or compression fractures or even osteomyelitis, because these patients sometimes will be inpatients and they're laying on their back constantly, and they can get those decubitus ulcers near their back that could spread into their bone, that osteomyelitis, infection of the bone. Positioning is the same. You're going to be supine. And you're going to be head first. You can't really go feet first yet. Feet first, we're going to start to be able to do that with the L-spine and the sacrum and coccyx. We're going to center our laser. ISO center is going to be at T4, T5. A little bit higher than you think, because you're thinking there's 12 thoracic vertebrae, but center at T4, T5, because remember, we still have to do those counting sagittals where we need to see the C-spine. So we have to maybe center a little bit higher than you think, T4, T5. That way, when we get that initial counting sagittal, we get all the way from C2 all the way down to T12, L1. You can see the protocol, MRI protocols. We have without, with and without, and then the spinal cord protocol. So a lot of the pathology we've talked about before, discitis, osteomyelitis with contrast. Compression fractures are typically just going to be routine. And then if they're looking at the spinal cord, it's really looking for those MS lesions within the spinal cord or any type of meningioma near the spinal cord. Here's our localizer, and you can see how far we get down. But look again, we got C2, so we can start our counting all the way down to L1. Some places they do a full sagittal spine so that it makes it real easy to be able to count either from the bottom up or from the top down. But if you do from the top down, make sure you open up your field of view. Your field of view has to be very big. Almost you have to max out your field of view, 500 millimeters or 50 centimeters or 450 millimeters, 45 centimeters. You got to max out that field of view to get the entire thing. And you'll start to see that warping artifact when you have those large field of views. And that's normal because you start to lose that homogeneity near the edges of your field of view. You're going to get the most homogeneous magnetic field at the middle. But you'll start to get the warping artifact with these very large field of views. But remember, we're just using this one to count. So you want to make sure that field of view covers from C2 all the way down to L1. We're aligning it with the spinal cord again. And then make sure it's an odd number of slices. Put a sat band over the chest to reduce that respiratory artifact. Then, for our actual sagittals, that's when we want to reduce our field of view so that we're really just covering the thoracic spine. So now we've covered C7, and then we go all the way down to L1. That way, the radiologist knows we covered the correct area, and we have all the thoracic vertebrae in there. That's typically why we send our localizers. The rads are looking to make sure everything was set up appropriately and any incidental findings. Sometimes with those localizer scans, they might see a tumor off to the side in, say, like the brachial plexus. Even though you're doing the C-spine, they see that, and then they'll call and say, maybe can you run a brachial plexus scan also, or they'll have to come back and get a scan another day. And then your axials. You're doing blocks. So you might get a high and a low because you can see you have an anterior curve, the top of your thoracic spine, and then due to your kyphotic curve here, you have to change your block so it angles more with the spinal cord, because you always want to be perpendicular to your spinal cord best you can. So you angle a little counterclockwise at the top, and then you would angle a little clockwise at the bottom to be perpendicular to your spinal cord. So that's going to give you best representation if there's any type of herniation of those discs. Sat band over it. And these typically are going to be longer scan times just because you're covering such a large amount of anatomy. Indications for L-spine. Much the same pathology, but I want to highlight the main ones that you really need to know, especially for the tests. Scar tissue versus reoccurring herniated nucleus pulposus. So you're really only going to give contrast on an L-spine is if they've had prior surgery, infection, or any type of tumor, okay? So if it's their first time to get an L-spine, typically you're not going to give contrast. But if they've had prior surgery, it could be metal or it could be like laminectomy where they didn't put metal in, you're going to be giving contrast because sometimes they're trying to differentiate between is scar tissue causing the pain, or did that herniation reoccur? Tumors and infection. Prior surgery, tumors, infection. And that surgery could mean that they've had metal implanted, or it could be as simple as like it's not a simple surgery, but a laminectomy where they just remove part of the spine to kind of reduce some of the nerve impingement. One that you would get called in, say if you're working at Main Hospital, Kiera, where you're on call on the weekend and they don't have an MR tech. One of the main reasons you get called in is for this urine incontinence. So this is one of those stat exams. They want to find out, why is this patient unable to urinate? They almost don't have any of that sensation in their lower half of the body. So it could be a very bad herniated disc, or it could be a tumor that's finally grown to the size where it starts to impinge on all those sensory neurons, basically. So this would be a stat exam, that urine incontinence you get called in for if you're on call. A call over from the ER. And then the other most common one is that pain, numbness, tingling down the legs, pain in the side of the legs, that sciatic nerve, right? Everybody has a little bit of sciatic nerve pain as you get older. I was driving with my wallet in my pocket for years, and I noticed I'd start to get that sciatic nerve pain, so I stopped. When I drive, I take my wallet out of my back pocket just because it was uneven. It was causing a little bit of pain. Things like that. That's a very common one, where as you get older, you get that back pain, and it's usually coming from that sciatic nerve, which originates from the sacrum. So that sciatic nerve is originating from the sacrum. So when you're scanning those patients, make sure you cover a little bit further down than you think. Sciatic nerve runs from the sacrum down their legs. So here's our coils once again, and the only difference is now we can accommodate those claustrophobic patients. So we can go feet first. Make sure you're giving that cushion under their legs, because that obviously reduces that back pain, makes it more comfortable throughout the procedure. We're going to be centering just the same as an x-ray, right? The iliac crest, L3, L4. So just feel, palpate for that crest, center there. Here's our MRI, our MRI specific protocols. Here you can see in red, this T2 space or cube is a 3D acquisition, and that it says only if it's available on the scanner. So you'll see little things like that where if you're at a site that has like maybe a 3 Tesla, you can get this 3D T2 compared to all the other sequences. And it's going to improve our image quality. But sometimes you don't need to run that because your scanner actually doesn't have that capability. So just be mindful of those. With and without contrast, that's when you're really going to be evaluating scar tissue versus re-herniating that disc. And then if you're looking at the spinal cord, so MS, any type of meningioma, things like that. Have you guys gotten pretty good at looking at those protocol books? Kind of differentiating what sequence you should be running, adding on pulse sequences, maybe if they didn't somehow come over from your scanner. It's your localizer. Once again, for your sagittals, you're aligning with the spinal cord. Keep that odd number of slices. Make sure you're covering from transverse process to transverse process. Get the entire vertebral body, because you don't want to cut off like the pedicle or the lamina, because a lot of those nerves they come out of that intervertebral foramina, and we need to visualize if those nerves are getting impinged upon by that intervertebral foramina starting to close. So make sure you're covering from transverse process to transverse process. Our sat band is now going to go over the abdomen. You could even add in another sat band kind of in this direction if you want, but make sure you're covering the abdominal aorta. You're going to get a big flow artifact if you don't. You're going to get respiration artifact if you don't put this sat band. So make sure you're putting this sat band to reduce any type of artifact streaking across your image in the phase direction. Even if they don't have a really big breathing artifact, just from peristalsis alone, your bowel contracting and relaxing constantly, digesting food could cause an artifact. All right, so your axials on your L spine are kind of the trickiest part of the scan. Some places do a block. Some places do individual slices through the intervertebral disc. What does Resurgent Roswell do?
They do like the individual and then the stacks.
Okay, so they do both.
Depending on
How the back is.
Yeah.
And you'll find it's a little difficult when you do the individual here because you have that lordotic curve, right? So L5S1 is kind of a disc space that's really hard to angle and not get what we call that crosstalk artifact. Crosstalk is when we have two slices going over top of each other, and the two slices, you're exciting two different slices, and they could cancel each other out. And what you do not want is something like this, where you have that crosstalk artifact across the spinal canal. So this is crosstalk, and this is the image this is how that tech probably would have set it up, by actually angling too extreme with the disc space, and we get two slices converging over the spinal canal. So you want it to look more like this, where you have some space in between the slice profiles, so we get good clearance within the spinal canal. If they cross way back here, that's fine, but as long as they don't cross within the spinal canal, you're okay. But here, this is a bad setup, and this is what it would look like. Resultant image of crosstalk artifact. So, like Nick said, you could either do a stack, or you could just acquire slices through, let's say, L1, L2, L2, L3, L3, L4, and then just do a whole nother sequence just for this L5S1 joint space. Okay? It might take a little bit longer, but you don't get that crosstalk artifact. One stack. One stack means that all your slices are going in the same direction. So if you got one stack, it would look something like this. And then all your slices would just be going in this direction. So they would never actually cross, Lily, but you can see how it doesn't really align with your intervertebral discs. So you want to angle this stack a little bit clockwise, rotate it to the right a little bit so that it's perpendicular to the spinal column, okay? But then it's going to kind of screw up down here because see how the spinal column kind of goes in and then out again? So that's why some places do a stack and some places do the individual slices. It's all just depending on where you're at. But Emory tends to do the stack, and Resurgence tends to do like the individual slices.
I've noticed they want me to do like a stack on like the very last one, like L5 S1.
Yeah, and that's what it is, because they just basically want to cover this area up here where you don't have much variation, and then just see how L5S1 is completely turned, and that's why. And also it's good too to get a little bit more of that sacrum just in case you have sciatic nerve issues. All right, now indications for sacrum and coccyx. And the big one here is a lot of people, especially inpatients, are going to be laying on their back, and they get these decubitus ulcers within the hospital. And that's why, nurses make sure that they're rolling their patients every half hour or hour to make sure that they're not developing these bed sores. But if a decubitus ulcer could turn into osteomyelitis, where that infection spreads into the bone, and that could be potentially deadly. Ankylosing spondylitis. Does anybody remember what that is? What's the other like slang term for it? Bamboo. Bamboo. What was the second word you said, Rachel? Bamboo spine. Good. So it looks very similar where all the vertebral bodies are starting to converge and fuse together, and you get that bamboo appearance of the spine. Avascular necrosis, this is where you might have a fracture of like the sacrum or the coccyx, and then you're not getting blood flow to a certain area of that bone, and that bone dies away. Rheumatoid arthritis, that's autoimmune. Osteoarthritis, just from old age and repetitive use. Psoriasis and gout. So you can see some of these things are you find in like the feet and in the hands. So we are still using our spine coil that's going to be behind the patient, but now we need to apply a flex abdomen coil on top of the patient to get signal from the front of the patient. So we can do this feet first if they're a little claustrophobic. But the only difference here is we should not be using a big cushion because we don't want to elevate the legs too much, just a small cushion under their knees for comfort. We're going to be centering our laser light almost just like x-ray for a pelvis, 2 inches below the iliac crest or a little bit below the ASIS. Here is our MRI protocol. This is from our MSK because we're really dealing more MSK than actual spine when we're dealing with the sacrum. So this is our MRI protocol here. Here's our localizer. You got your sagittal, your axial, and then your coronal. So your coronal is going to be oblique. It's a coronal oblique. So you're going to want to angle with the sacrum, and maybe if it is coccyx specific, maybe take a little of that angle off so you can see the coccyx a little bit more in profile. But you want to make sure you cover from SI joint to SI joint. And you need a lot of oversampling because you're really covering the anatomy that's in the middle of the patient, and you don't want their hips to wrap into the image. So make sure you have 100% oversampling to avoid that wraparound, phase wraparound. You could put a sat band here if you'd like, or over the abdomen. Axial oblique, 90 degrees from your coronal oblique. So you're almost going through those little, they would be almost considered intervertebral disc spaces, but they don't have actual discs. But we know we have several different parts of the sacrum, so you could go 90 degrees from that. But make sure you're getting from L5 all the way down through the sacrum, and if you need to cover the coccyx, open up your amount of slices. All right, so let's talk about some pathology of the spines that you might see. Some of these things you can use for your PowerPoint presentations if you'd like. Syrinx, we already talked about that. That's where we have a fluid getting into the middle of the spinal canal, into the spinal cord because of excess pressure. That could be from a Chiari malformation or some other type of pathology within the posterior fossa. And that's very painful because it's pushing that added pressure. So a lot of neck pain associated with these syrinxes. Spinal meningioma, so benign tumors, but it's in the spinal canal instead of near the brain. These are not life-threatening unless they're impinging upon something that is very important, like obviously your spinal cord. So paralysis could be an issue. And these are typically tumors that are very hard to get to. The spinal surgeon is going to have a hard time deciding, do I want to have this patient go into surgery because I could permanently paralyze them if I nick something, or it's just impossible for me to access. So you can see here how this could cause the patient to be completely paralyzed just because it's impinging upon this C-spine, spinal cord, pretty high up, almost near the brainstem. But it is a very round tumor, meaning it is benign, but the only danger here is what it's impinging upon. So if it's very small, they could just monitor it over the years. Compression fractures, so T-spines are prominent when we're dealing with compression fractures, and right at that kyphotic curve tend to be the area that you get the most compression fractures. Another point would be like around T11, T12, because you don't have full ribs there to help support those vertebrae. You have those floating ribs, so it's a little easier to actually fracture, have compression fractures of T11, T12. So that's going to be a very common area that you get those compression fractures. And a fracture on a T1 weighted image is you're going to be a hypointensity. So hypointensity of the fracture site compared to hyperintensity vertebral bodies. So you have fat within the marrow of the vertebral bodies. Fat is bright on a T1. So the vertebral bodies normally look pretty bright. But if you have any type of pathology, it could be a tumor, it could be a compression fracture, those things are going to be dark until you inject contrast. So a T1 weighted before contrast, the pathology is going to be hypointense to the vertebral bodies. Discitis, inflammation of the intervertebral discs, and then you can see that infection has spread to the vertebral bodies. This is a T1 pre-contrast, and you can see how that is, the pathology has hypointensity signal. But then you inject the contrast, and we know there's contrast within the spine because here are some of the blood vessels feeding the vertebral bodies. You'll always see a little bit of hyperintensity on the posterior part of the vertebral bodies post-contrast, and then that pathology lights up post-contrast. It's fat-satted also. And then our hernia nucleus pulposus, most common. Here the herniation is not only going posterior, but it's going inferior. So it's now herniated back and down. So this is why when you do those individual slices, you need to make sure you cover the whole pathology. So don't just get 3 slices, one on top, one through the disc space, and one on bottom, because you might miss some of the pathology. So make sure you do a little bit of almost a small stack right here to get the entire pathology. And then here's our decubitus ulcer when we're talking about sacrum and coccyx. I think this patient had a lot of pain on that side. That's why they put their hand back there to support where that decubitus ulcer is. But this is a fat-satted image, T2, or a stir, and you can see the pathology bright, the decubitus ulcer. And they're concerned with this decubitus ulcer, the bed sore, spreading to the bone. Because once it spreads to the bone, they're going to have to use a lot stronger antibiotics, and the patient might not survive a osteomyelitis compared to just a bed sore. All right, so that covers our spine. Any questions about that? All right, so that'll be the end of the lecture for today.